All right, I think everyone is here. So let's begin. So we're very pleased to welcome back Nathan Cherny. I think it's Nathan's third time, but Nathan is very prolific in publishing very important work. So Nathan is professor of clinical oncology at Sharazadek Medical Center in Jerusalem. And today he'll be talking with us about his new paper on taxonomy of the factors contributing to the overtreatment of cancer patients and the end of life. So Nathan, please, the floor is yours.
Thank you very much. Um, this has been a co-joint work which was done by myself and oncologists from MD Anderson, Canada, Germany, and Austria. And the publication is freely available on ESMO online. Okay, so I'll get straight into it. In managing patients with far advanced cancer, oncologists walk a very fine line between, on one hand, wanting to maintain hope, and on the other hand, to promote the interests of their patients. And that fine line is a line between giving effective treatment that is truly helpful that provides substantial benefits, and overtreatments that cause more harm than help. By definition, I'll try to define overtreatment. Overtreatment is the use of medical interventions that are unlikely to provide meaningful clinical benefit to a patient, with a high probability of causing more harm than good. There have been numerous papers looking at the prevalence of overtreatment in cancer patients, and the estimates are somewhere between 10 and 40% of patients are overtreated in the final weeks of life. It tends to be higher or more common, a bigger problem in males and younger adults, and in hematological malignancies. And we can see a trend with a rising incidence of overtreatment with immunotherapy and molecularly targeted therapies at the end of life. The overtreatment related to treatment modalities can relate to either systemic anti-cancer therapies, radiation therapy, or surgery. But in this discussion, we're going to focus on the non-beneficial use of anti-cancer therapies at the end of life. Now, there is a differential diagnosis, and the differential diagnosis is one, patients who have a relatively good performance status despite having advanced disease, who participate in early phase research studies. And secondly, well-informed, fit patients who request a trial of treatment with a low but evidence-based prospect of meaningful benefit. ASCO has really taken a great lead on this subject, and in their Choosing Wisely document, they have a very strong admonition: don't use cancer therapies for solid tumor patients with the following characteristics: either a low performance status, no benefit from prior evidence-based therapies, and when there's no strong evidence supporting the value of further therapies. In this situation, they say that treatments are likely to be ineffective and more toxic for patients. They do describe an exception, and the exception is when there are disease characteristics suggestive of a high likelihood of response to therapy that may reverse the functional limitations related to a cancer. So now this would possibly relate to a patient who presents, in a near-death situation, say with small cell lung cancer, who may have a high likelihood of responding. ESMO has also incorporated this approach in their guidelines regarding patients at the end of life. What do patients want at the end of life? And there's conflicted evidence. Some of the older studies suggested that patients would be prepared to undergo another trial of therapy for even a small chance of benefit. But more recent studies give a different picture. There have been a series of studies looking at the survival gain threshold, how much survival patients would want to justify a further line of therapy. And there are three recent studies. There was a German study looking at patients with colorectal cancer and other cancers, and the median additional survival threshold for further chemotherapy, these are all patients who've had chemotherapy, was for colorectal patients, they'd want another 33 months of life, and for other cancers, 18 months of life. In a separate study looking at metastatic pancreatic cancer, the minimal survival gain threshold for additional treatment was between 1 to 5 years for 32% of the patients, and more than 5 years for 11%. Now, this is what FOLFIRINOX actually provides. FOLFIRINOX in a first-line setting offers a survival advantage of 4 months. And in a study of patients with head and neck cancer, with an anticipated survival of less than a year, the minimal expected increment in life expectancy was more than a year for 190 of the 200 patients. So, patients are wanting a lot more than what we can actually deliver in this setting. The group at MD Anderson did an important recent work asking the question, does aggressive treatment at the end of life improve overall survival? And they looked at a cohort of almost 80,000 patients with 6 common tumors in 144 practices. And they looked at the practices that had the highest incidence of treatment in the last 2 weeks of life, comparing the practices with the lowest incidence. And they found that there was no difference in overall survival in the high treatment practices at the end of life and the low treatment practices. So that sort of suggests that these additional treatments are not prolonging people's survival. The harms of overtreatment can be classified into 3 subgroups: patient harms to the enhanced risk of adverse effects, increased risk of hospitalization, the diminished quality of life, time toxicity, inflated expectations from treatments that undermines true informed consent, and which delays important discussions about end-of-life care. There are economic harms, the strain on public health resources, many strains often on the personal resources of patients and their families, and the use of large amounts of funds for expensive drugs at the end of life diverts important resources away from more robust palliative care services. In terms of the staff, very commonly there's issues of moral distress, guilt, particularly amongst the nurses who have to administer these treatments, and often in hindsight, guilt and remorse on behalf of the oncologists. And a lot of these issues of overtreatment at the end of life are major factors that contribute to both nursing burnout and to also oncologist burnout. There is what I call the collusive illusion of limitless solutions, that the reflexive prescribing of further anti-cancer treatments to patients with advanced cancer promotes a collusive illusion that there are limited therapeutic solutions with many resultant risks and harms. A key issue here relates to the process of decision-making. And the decision-making, there's a dynamic between the patient, oncologist, and the family, where one interacts with the other. All of them are being affected by psychological factors, cultural factors, and cognitive biases. So these are complex, fateful decisions, difficult decisions in fateful and emotionally charged circumstances, where the decision-making is influenced by this very complex interaction between these different parties, each of them being influenced by culture, psychological factors, and cognitive factors. And I guess the underlying hypothesis of this talk is that this very complex confluence of human vulnerabilities, of cultural, psychological, and cognitive vulnerabilities, render us prone to interventions at the end of life that, despite good intentions, are often harmful, and that this is a difficult cycle often to break out of. Now, what I'd like to do now is to review and to look at these different psychological, cultural, and cognitive factors. I'm not going to go through all of them, but I'm going to highlight many of the important ones. Fear of death is a potent motivator to patients, their families, and physicians, and it often leads to a desperate clinging to anti-cancer treatments. When you ask oncologists, they often perceive that aggressive anti-cancer treatment at the end of life is being driven by the patients, and they will often rationalize their prescriptions as an effort to palliate their patients' emotional distress, even though they don't have a lot of expectation that it's really going to be helpful. Oncologists commonly fear causing emotional distress to patients, shattering patients' hopes, and needing to deal with patients' distress. And out of these fears, they often become avoidant of crucial conversations regarding the end of life, and it becomes a lot easier to just say, look, I'm not going to get into all of this end of life talk. It's just going to be easier to suggest another line of treatment. And the late psycho-oncologist at Sloan Kettering, Margaret Lederberg, would call this the counterphobic determination to treat. Hope is a powerful motivator, particularly for patients. And the uncertain possibility that a new treatment may provide benefit is often preferred over the perceived certainty associated with a palliative care option with no anti-cancer treatment. And many oncologists perceive their professional role as to sustain hope, and as a consequence of that, they try to actively avoid guiding patients into end-of-life discussions, which they both perceive as a loss of hope. Sometimes patient denial can prevent patients from fully understanding the implications of far advanced and refractory cancer. They will sometimes resist being informed about what the true nature of the situation is. And this can lead to prioritizing aggressive treatments over informed decision-making. They don't want to receive that information. And patient anger can lead also to a fight-back mentality. For many oncologists and their patients, they see the continued treatment as a way of asserting a sense of control over the cancer. And they see, in the contrast, on the flip side, that the transition to palliative care would be relinquishing control and becoming dependent. So this doing something or doing another line of treatment can promote an illusion of control, even when the control does not objectively exist. Both oncologists and patients can suffer from decision fatigue. This is the mental exhaustion from repeated needs to make decisions, the volume of information to be presented in the consultations, emotional distress, and the issue of just resorting to a default, and that default being is another line of treatment, can be a default mechanism both for oncologists and for the patients and their families. Very clearly, the dynamics of the oncologist-patient relationship impacts on treatments. This is usually a relationship with a major power imbalance. And oncologists have the power because, one, they have knowledge. Secondly, they are in control of what they choose to discuss or disclose, or what they choose not to discuss or disclose. and they also control how they present issues such as prognosis and the likelihood of benefit or harms from further treatments. There are a number of common communication shortcomings that have been highlighted in this setting, particularly presenting an overly optimistic prognosis, an exaggerated likelihood of benefits from treatments, not being explicit about the limitations of treatment in terms of likelihood of response, likelihood of feeling better, or the usual amount of life prolongation, or discussing worst case scenarios. And by not addressing important issues around end-of-life care, such as the potential need for admission to hospital, the risk of severe adverse effects, the opportunity cost, what's lost by spending time in a hospital, and issues of time toxicity, and in many cases, when expensive drugs at the end of life aren't reimbursed, the very substantial financial toxicity that affects both the patients and their families. Even when oncologists present treatment options clearly, many patients don't fully grasp the limitations of treatment. When the doctor says that there is a chance of remission, patients and their families often hear that there's a likelihood of cure. And this sort of misunderstanding can also be a driving factor. Sometimes patients pressure their oncologist to pursue overtreatment, even when then further treatments are not advisable, resorting to issues of crying, rarely, in my experience, threatening legal action, but that's described in the literature. And complying with these sort of requests for oncologists may just be a path of least resistance. And this path of least resistance often involves what's been called in an article in the JCO from about 20 years ago, necessary collusion, where the patients and physicians make a collude together to avoid discussing prognosis and the limited likelihood of benefit openly. Now, there are things that oncologists can do to mitigate against this. When patients perceive their oncologist as trustworthy, as caring, as deeply empathetic, they are much more likely to accept the option of palliative care as a preferred strategy of care. When I say to my patients, further treatment is more likely to harm you than to help you, and I really don't want to harm you, more often than not, my patients will go along with that. One of the issues that's been brought up in our discussions was that in settings where patients don't have continuity of care, where they're seen by a different trainee every couple of months, it is very difficult to build this degree of trust to enable people then to subsequently deal with these difficult transitions. Okay, now moving on to some of the social and cultural issues. Cultural norms and beliefs about death and dying. In many cultures, death is viewed as a defeat or failure, and this is actually quite pervasive in Western culture. Increasingly, there is a societal expectation to fight cancer. There's a glorification of fighting the disease, and this is reflected in the language of the war against cancer and the battle against cancer. And this promotes a warrior mentality with a pressure to pursue all possible treatments. And in this battle narrative, palliative care and hospices are stigmatized as giving up. Hype is a huge problem, and it is propagated by the lay press, by cancer centers, by social media. We have here a whole host of headlines of improvements in cancer care over the last 20 years, and the reality that the improvement in median survival in this period was 2.7 months. So this sort of hype in the community creates inappropriately high expectations of what new treatments will do, particularly in the setting of end-stage cancers. In many cultures and religious beliefs, belief frameworks, enduring pain and fighting the disease is seen as morally and spiritually commendable, and that ceasing aggressive treatment can be seen as either dishonorable, some sort of a moral failure, in some religious beliefs, a reflection of a lack of faith in the higher power. And on the other side, belief that miracles can occur, even in the most advanced cancers or stages of illness, leads to patients to adopt a philosophy of therapeutic exceptionalism. That that may happen to everyone else, but God is on my side, and my outcome is likely to be different. Patients are often commonly influenced by the emotions and desires of their family members. And we're all familiar with a scenario of the family member who comes from abroad, who's not been around, who suddenly wants to push for continued treatment as a way of showing their love and commitment to the patient. The pervasive medical culture is also important. And this affects physicians' attitudes towards death and dying, whether a perceived duty to exhaust all options, this is something called the therapeutic imperative, and therapeutic optimism. And all of these factors can tend to overshadow critical evaluation of the effectiveness and suitability of treatments. Looking at oncology specifically, oncology training emphasizes the life-prolonging approaches to therapy, and it does not give great emphasis to issues of harms. It frequently teaches residents often can finish a residency not knowing or not when to stop treatments, and often there is inadequate training in end-of-life care and in the communication skills that are necessary to be able to deal with these sort of discussions. The role of hope preservation makes oncologists concerned that their honest communication will take away patients' hope. Many oncologists want to avoid therapeutic nihilism. They don't want their peers to look at them and say that they've given up on a patient. And sadly, a proportion of oncologists do not consider end-of-life care to be a part of their professional role. And all of these things can lead to this default approach of continuing the search for yet another treatment. In terms of incentives, academic promotion and professional status is heavily incentivized by enrolling patients in clinical studies and drug discovery. Academic promotion and professional status for oncologists is not promoted by communication skills, interdisciplinary care, and palliative care. And in many specialist cancer centers, they are often largely funded by research income from clinical trial enrollment, and this can make it often a taboo to stop therapies and to pursue holistic end-of-life options, rather to look, well, is there another trial we can get the patient into? There may be financial and legal considerations impacting oncologists. In some countries, there are financial incentives to give further treatment, particularly where there's fee-for-service payment to oncologists, including a proportion of the cost of the drugs, and per fraction billing for radiotherapy. A fear of litigation, again, I've heard this, I've never experienced this in this sort of setting, but for some people, being very aggressive with treatment at the end of life is an expression of their defensive medicine, that they don't want to be accused of depriving a patient from an option that may have been described in a recent phase 1 and phase 2 study. When people have looked at the studies, looking at the prevalence of overtreatment at the end of life, it's clear that there is clustering in institutions. There are some institutions where it is much more common than in other institutions. So there are institutional and departmental cultures regarding the aggressiveness of anti-cancer care at the end of life. Also regarding the degree of integration of palliative care, and also influenced by the availability of palliative care services. If you don't have these services, then you may have a tendency to prescribe more treatments at the end of life. And so we see these very substantial differences between hospitals and between hospital departments. In discussions with my oncology colleagues, they say, look, the time pressures that they have on them makes it difficult to have long, thorough, empathetic discussions about end-of-life care options, about patient values and goals. And because these discussions do take time and are emotionally challenging, it is often easier, again, just to offer another line of treatment than to invest the time into this other aspect of care. The third aspect, or the dimension here, is the issue of cognitive biases. In decision-making, it is said that people spend about 95% of their time in an intuitive, fast-thinking time using shortcuts and heuristics. And these so-called cognitive shortcuts can be anchoring defaults that allow us to apply our mental and emotional energies elsewhere. And these can contribute to overtreatment in oncology. Now, where do these biases come from? Some of them come from natural selection, that they've been selected in our evolutionary past. Some of them are driven by our emotions to pursue happiness, to avoid sadness, fear, surprise, anger, or disgust. Sometimes we overlearn patterns of behavior, and another lot of biases come from role modeling and implicit learning. It's not something that you're ever taught verbally, but you see your mentors and the senior people in your department behaving in this way, and you learn, well, this is the way to behave. A major bias is optimism bias, and this refers to the tendency to overestimate the likelihood of positive outcomes and to underestimate the likelihood of negative outcomes. And this can affect oncologists, and it influences their tendency to communicate unrealistically optimistic expectations to patients and their families. And in doing so, they undermine true informed consent. And optimism bias amongst patients, which can be reflected in a sense of hope that they will be an exception to typical outcomes. Confirmation bias often goes hand in hand with optimism bias, and it's a tendency to seek out information that confirms one's existing beliefs. And it often leads oncologists to focus on the benefits of new research findings and to minimize or ignore adverse effects or costs, and to minimize or to ignore issues of bias in the study's design, implementation, and interpretation, such that they're looking at the research results through these rose-colored glasses. Novelty bias has also been called the seductiveness of new technologies. And this is the allure and excitement surrounded by new breakthroughs. The latest thing will give better results, and the desire to be at the cutting edge of oncology. It can synergize with confirmation bias, that they both lead to a suspension of clinical evaluation and overlooking of harms. But the downsides are the rapid adoption of new therapies supported by low-level evidence of efficacy. Often these new agents have unique adverse effects, some which have major long-term consequences. They often involve substantial financial toxicity. And when there's often a large gap between the anticipated outcomes and the actual outcomes. And in truth, many of the accelerated approvals are withdrawn due to lack of confirmatory data. Another cognitive bias is recall bias. This is the tendency to overestimate the likelihood of benefit based on recall. That we remember the exceptional patient, like this guy here, who had a dramatic response to his mediastinal and cervical lymphadenopathy, but you forget the patients that die, and this sort of selective memory can trigger us to repeat patterns of behavior. Some of the other biases that are common are overconfidence bias, a loss aversion bias, where patients, oncologists, and the families have FOMO. They have fear of missing out if they don't try, everything possible. The bandwagon bias, where oncologists feel pressure to adhere to the prevailing treatment practices in the departmental norms, particularly where the norm is to be aggressive at the end of life of care. And it's not easy for someone to speak up in the multidisciplinary meeting to say, look, the emperor has no clothes. This really is not going to be a valuable treatment. It is more likely to harm than to help. Framing bias, that oncologists often frame potential outcomes from new treatments in probabilistic terms, which are easily misunderstood. It has a 30% chance of reducing the likelihood of death, rather than saying that it has a likelihood, a 20% likelihood of increasing your life by a small number of months. The affect heuristic is where our behaviors are driven by our emotions. That oncologists will often say get emotional relief when they present a positive prognosis or another treatment option, and they do not get emotional relief when they're having to discuss end-of-life care. So putting all of these things together, what we can see is that this is an extraordinarily complex situation. That these factors are very human, and that these human vulnerabilities make us prone to interventions that, despite good intentions, are often harmful to patients nearing the end of life. And we need to be aware of them and cautious about it. Because these well-intended treatments for frail cancer patients who are near death are more likely to harm than to do good. So where possible, to be aware of that and have the insight and to try to avoid this practice. So changing practice is notoriously difficult. And the sorts of interventions that have been tried thus far, single interventions have really not moved this practice at all. And moving this is going to require a host of things, including upskilling oncologist communication skills, issues of organization, of scheduling, palliative care team availability, psychosocial and spiritual carers, helping change the role definition of the oncologist, looking at emphasizing harm prevention, being a personal steward to the patient, emphasizing end-of-life care, and teaching people about their biases to make them aware, or to give them self-awareness about them, and to encourage a more mindful practice in making decisions. There are some excellent resources, particularly about how to conduct these sort of conversations, and these resources are freely available online. The ASCO Choose Widely guidelines I think are always a very good backstop. And ASMO and ISMO guidelines emphasize shared decision making, that there should be regular discussions about prognosis, about the treatment goals, and what goals are relevant to the patient. about integrating palliative care early and discouraging this sort of treatment, over-aggressive treatment at the end of life. We're going to need also to address issues of culture, both the professional culture, the public culture about death, and to try to normalize discussions about death and dying, and to promote the idea that a good death is indeed a positive outcome, and to focus on end of life outcomes, the outcomes that matter the most: that physical comfort, emotional well-being, and maintaining functional independence for as long as possible. I'm going to finish off with an approach that I use in my clinic, which is a 12-step approach in handling these discussions. I first, when the patients and family come into the room, I will say, look, this is going to be a difficult conversation. In the discussion, one needs to prioritize honesty and transparency when discussing the diagnosis, the prognosis, the treatment options, and expected outcomes. I need to explore with patients what their priorities are. Quantity of life versus quality of life, issues of symptom management, spending time with loved ones. It's important to set realistic expectations regarding the likely outcomes of different treatment options, including the option of palliative care without further disease-modifying treatment. I emphasize that this is a deeply personal patient decision, and that authentic decision-making requires having accurate information. These discussions and with responsiveness to patient and family distress, obviously. I'll often say to patients, I don't want you to make a decision about this now. This is too important an issue. Let's take a time out, think about it and discuss it with the relevant and important people in your family, and let's continue this discussion either tomorrow or later in the week before we make a final decision. I will often to talk about courage, and pointing out that when people think about courage in cancer patients, they often emphasize the courage to take another treatment, but I emphasize that there's also a no less important courage in being able to look at the situation and say, look, this is really not good for me anymore. I'm going to step away from these anti-cancer treatments and focus on these other issues that are more important. I work with a team of psychologists and spiritual care providers and palliative care nurses, and they will often be in these conversations together. And I use them to help patients, often in debriefing after the discussion, or during the time of subsequent care, and they've often not been involved even beforehand. I will often talk about hope and emphasize that it is not productive to put all of your hope eggs into the basket of cure or chemotherapy drugs, because it's not going to hold, and that there are other really important hopes that are relevant to them, hopes that they can enjoy their important relationships, hopes that they can fill their remaining time with activities and relationships that are meaningful and important, the hope that the time will be as rich as possible, and the hope to leave a legacy behind for family members. I never use the term there's no treatment. Rather, I will say that giving further anti-cancer treatments are more likely to harm than to help, and we need to shift to a different sort of a treatment, emphasizing that I will still be there as their doctor, irrespective of what happens, even if there's no more anti-cancer treatments. Now, in that sort of framework, many, if not most patients will agree to forego further treatments, sometimes not. And if despite all of these considerations, patients still request treatment, I will say, look, if the treatment does not place an unreasonable burden on limited healthcare resources, to agree to a trial of therapy. And that's to say, to try something with the understanding that if we see that it's causing harm or that it's not working, we'll stop it. That is also the option that a proportion of my patients take. So with that, I'm going to conclude. I apologize that this has been a very fast overview, but I guess the message is that the factors that are driving overtreatment are really complicated. That we hoped that with this paper, that if the oncology community could be more aware of the factors that are driving the behavior, and that this behavior is causing harms, that it will promote a greater degree of introspection, both on an individual level and on a departmental level, and that it would provoke both individual clinicians and teams to start to look at the factors of what they can do to change this from being a default to rather the exception. So I'm really keen to get feedback from you and to open this to discussion. So thank you very much.
Thank you very much, Nathan. And I would like to ask you to turn on your cameras and raise your hands to ask Nathan questions. And in the chat, there were a few very thoughtful, very important comments. So I appreciate you putting them there because they will show up under the video when we post it on YouTube. And those people who might have missed the discussion can actually see them. So we have a question from Charlie. Please go ahead. And we don't see you, but it's fine. So please go ahead with your question.
A question from me would be, I don't know why my video is not working, but great conversation, great structure. And as an oncologist, it really is helpful. And I think it's something that we should be able to try to incorporate in our practice. The kinds of questions I would like to ask, though, is we in the U.S., one of our factors you addressed, but that's really huge, is the economic factor. And the economics is overwhelming. And so all the factors that you put in there are dominated by the economics. And the second thing is, in the U.S., and I wanted to see if you could address, is a lot of these overtreatment factors may not be too toxic, but definitely don't do anything good. And in your original conceptual framework, you had sort of this dichotomy of not very effective and also pretty toxic. And we are very comfortable now in the United States in giving you something that doesn't work at all, but that's not very toxic. So we can try to push you towards it. So what do you think about that change, a slightly changed in paradigm?
Yeah, well, I'll actually relate an event that we had this week. We've been, in our department, we've been looking after a 45-year-old Palestinian woman with far advanced pancreatic cancer, which has failed 3 lines of chemotherapy, and she was really having palliative care, home-based palliative care. She was bedbound at home, and her family dragged her to a different hospital to get another opinion, and a doctor has given her nivolumab. She 48 hours. I mean, and this was based on a phase 2 study in patients with a performance status of 0 to 1. And she 48 hours after the nivolumab, she presented to us almost moribund. Nivolumab is often seen as relatively innocuous single agent treatment. But when you're giving it to patients with a performance status of 3 to 4, and with a resistant disease, there was really no meaningful likelihood this is going to provide benefit, and she has suffered all the severe side effects, and her family is out $15,000 for the drug that they needed to buy. Now this is just really bad. Now this is bad medicine. So when given to patients with very poor performance status, immunotherapy and targeted therapies are often can be very toxic.
Thank you, Nathan, for this example. Piers, please go ahead with your question.
Thanks. It's a very interesting conversation. So I coordinate a very large real-world evidence consortium with about 40 hospitals. And clearly end-of-life care is one of the things that's much easier to study in real-world evidence than it is in trial. And one of the things I just wanted to share with the group is my comment in the side that gives you a sense of the things we're looking at, is where we started out our consortium is in guideline compliance research. And one of the things we've learned from doing that is because it's always hospital-led, there's always a PI on every protocol. And what we found is they're normally, because it's digital stuff, they're normally the younger end of the oncologists. And then they become an advocate for change in their hospital. And as I've been thinking about de-escalation and end-of-life care as a sort of possible sort of research frontier for our consortia. And it's one of the reasons I turned up today is to sort of learn more. The more I hear, the more I think that there's an opportunity here to sort of think about how we use kind of a mixture of digital and social science research methods to really start to unpick this more. And I also think there's the right funding schemes in Europe, which are the Marie Curie doctoral networks, which favor both training and multidisciplinary approaches. And I just wanted to sort of just say, you know, is that something that would be of interest to experts on this call? Because we've got the sort of the methods and the data, but I'm going to sound like Manuel in Fawlty Towers for those of you who do ancient UK Cherny. I know nothing about the proper bits of end-of-life care, and that's, you know, you only win those things if you've got the right multidisciplinary expertise. So just a sort of comment and an observation that might open up broader discussion about research frontiers. Does anyone have a view on that? Anyone tried real-world evidence on it?
Well, I would say that the study that was done by the MD Anderson group was a real-world data study. Where they looked at the outcomes of hospitals with a very high prevalence of overtreatment, comparing their outcomes to the hospitals with a very low prevalence. But the outcomes that they looked at were only in terms of survival. I'd be curious in similar situations to look at the psychological well-being of the oncology nurses and the oncology staff. I think
that's the sort of thing that's very, very favoured by Marie Curie doctoral network reviewers. That combination of multidisciplinarity. But our consortium knows nothing about that side of it. We can do the MD Anderson piece. We can't do the other bit.
Yeah.
Here's this is very interesting initiative if, once again, it can be funded, but it's very unfortunate that the appetite for such important studies is not in the right place. So it's...
But that's why I love Marie Curie doctoral networks. You don't have to do super sexy science to win. You just have to have a really good multidisciplinary training program. They're the stealth bombers of getting funding into niche areas.
Well, good luck. So we definitely can't wait to welcome you in Consilium to keep us posted on the progress. And if we can assist in any way, that would be great. Any other questions, comments? Andrew, please.
Yeah, it was Nathan. It was such a really good talk. Thank you for sort of exploring such an important issue and also laying it out so clearly. It was really good. And as you were talking, I was just reminding myself that I've just finished 4 years as a non-executive director on a hospice that covers sort of central and south London. And I mean, obviously, in my career in the NHS, and particularly when I was running hospitals, I was obviously aware of the hospice movement. But spending 4 years as a non-exec has been really illuminating, both in terms of how services are being provided, how services are being developed more and more in the community in people's homes. But it also just struck me how distinct hospice care appears to be from from the continuum of care of all of us, whether it's whether we're reaching the end of our lives with cancer or with some other condition, how it feels a bit like a cliff edge. So in the UK context, we've got the NHS and it's doing what the NHS does, given the nature of the condition or disease that we've got. And then it kind of comes to the end and we can't do any more. So now it's over to hospice care. And you kind of fall off a cliff into hospice care. I mean, that's probably the wrong analogy, but there seems to be such a disconnect between the two things. And I just wonder, listening to what you said, and also just reflecting on what Piers said a moment ago, whether there's something that we can do to kind of fix that disconnect so that there's a much better integration of I don't know what people might regard as the active part of treatment in cancer or any other condition when we're trying to, extend life or improve quality of life. And the point at which those things become impossible or undesirable, as we've just been hearing, because the side effects are too great, and we want to migrate to something else. And at the moment, it feels such a big decision, as if we're going into a completely different world. But if we could integrate them somehow more effectively, so that we're managing the totality of our care from the point of diagnosis of something that might well be fatal or is going to be fatal to the point at which we reach the end of our lives. It might make some of the decision making, Nathan, that you were talking about, which is so freighted with complexity of all kinds, a bit easier for everybody involved, patients, family members, as well as the professionals who are looking after us.
I totally agree with you that where these transitions can be done gradually, where palliative care works side by side in the oncology day hospitals as an integral part of the team. Patients get to know the palliative care staff when they're still receiving maybe their second line treatment, even sometimes first line treatment when they're symptomatic. And they are a part of the team, the care team all along. And as the situation gets worse, the role of the palliative care team becomes greater. And so it rather than become a cliff edge, it becomes a smooth transition. This is what the model that we've developed in our institution in Jerusalem. And also, this is the model that ESMO, the European Society for Medical Oncology, has promoted over the last 20 years, where they have a designated program, a designated centers program in integrated oncology and palliative medicine. It's an incentive program for centers to develop these sort of integrated programs, get recognition for it. There are now 300 recognized designated centers around the world. And by giving them this sort of designation and publicity, the hope is that it will incentivize other centers to follow suit and develop these sort of services. So there is momentum there.
Right.
It's still probably not enough.
Yeah. And I think, just if I can come back just very quickly, I don't know if part of this work is exploring the labels that we apply to different kinds of care, so that everything oncologists do is treatment, and then everything that palliative care physicians or hospice care is not treatment, it's something else. And yet that's not true. I mean, it's all treatment. It's all attempting to give us the best possible quality of life for however much life we've got. And I wonder whether a bit of relabeling, just something around the language, being adapted so that this continuum of care, which is treatment all the way through to the end, might be helpful, I think.
Thank you so much, Andrew, for these very helpful observations and comments. All right, Nathan, thank you so much for a very, very insightful talk. We learned a lot, and very pleased to have you back with us. So thank you for teaching us. And I wish everyone happy holidays, and we'll be back actually next week. So we're slightly off the schedule. So hopefully we'll see some of you next Thursday. All right, bye-bye, everyone. Thank you, Nathan, once again.
Thank you. Bye.